Very good, Andrea Milzi. Welcome here in this interview. This is a delayed interview from the EuroPCR, where the plan was to have the interview at the booth, but you were not available there, so we decided to do it afterwards, but still discuss the work that you have been doing, of course, in the field of QFR and IMR. And you are from the University Hospital in Aachen in Germany and have been working with the QFR and the different applications already for quite some time and published about it. And yeah, we decided for this interview to discuss two topics. The one is your work on the INOCA patients, so with an index of microvascular disease, and that was published in Frontiers in Cardiovascular Medicine. And the other one is on the 10 frames per second. And as everybody knows, for the QFR, we expect that the minimum frames frequency is 12.5 frames per second or higher. But of course, due to respect of radiation dose, daily practice, that also lower frequencies, frame rates are also preferred. And you did very nice work also in this field, and that is now under review at Circulation and Cardiovascular Interventions. So maybe let's
Yep.
start with the first topic. What can you tell about your experience and the results that you have achieved on the index of circulatory resistance in INOCA patients, and where you use the special, the research solution at this moment for the QFR IMR, as we call it, also a meta solution.
First of all, Hans, thank you for having me. It's a pleasure to be able to talk about this research and the opportunities that QFR is offering nowadays. So this first piece of research, it is the one that is published in Frontiers, and we've studied angiography-based index of microvascular resistance in a population of patients with INOCA, so with ischemia documented in cardiac MRI, stress MRI, compared to patients who did not have any ischemia or to patients that did have ischemia, but as a consequence of obstructive coronary artery disease. And this is important, I think, because often we do not have the information regarding invasive IMR because of the cost of the wires, of the trouble of bringing the wire down. And oftentimes what we hear is, okay, the patient has no coronary artery disease, and we know from several data that this is not enough nowadays, because we have a lot of patients with INOCA that are often misdiagnosed or underdiagnosed. And I think this is a very promising field for angiography-based physiology. So QFR has a real nice place. What we did study in this, what we did find in this population, is that angio-IMR, so an angiography-based index of microvascular resistance, is higher in patients with INOCA than in the other two populations. So angio-IMR is effective in diagnosing a microvascular dysfunction in these patients. And the second finding, which I find extremely interesting, especially from a conceptual perspective, is that angio-IMR is not the same in every vessel. So we saw an angio-IMR which was higher in the vessels which were perfusing areas of myocardium which showed ischemia. So it looks like we have some kind of microvascular dysfunction overall, but this microvascular dysfunction can be more pronounced in precise areas of myocardium, which co-localize with the ischemia. And that's, I find, extremely promising, but as well extremely fascinating how we're able to perform this physiological evaluation on all three vessels just by doing angiography and analyzing it better. So
yeah, no, absolutely. So that means, I mean, I believe you also found some cutoff values. So that means and there is the microvascular resistance above a certain threshold, but that threshold is then also dependent on the vessel or on the amount of ischemia that is present in the patient.
The thresholds are different probably for the vessels. I think we didn't have a big population which was big enough in order to analyze different thresholds for different vessels. So we just took the higher value for all vessels and using it to build a threshold overall for defining microvascular dysfunction. But it is, of course, also important to detect, also important to acknowledge for the differences in the different vessels in regard to thresholds, which is a thing we also do not know for invasive IMR. That's only validated actually for the left anterior descending and not for other vessels. So we do not have proper thresholds for those ones.
Yeah. So this, aside from being that it is a non-invasive approach, yeah, you can very easily calculate the index of microcirculatory resistance. But in addition, of course, you can do it in all the vessels, and do this invasively is enormous effort. For it not pleasant for the patient. It costs a lot. So this is something that and basically it should be available, I think, in every patient, that whether you have obstructive disease or not, but that you have a measure of epicardial disease, plus also maybe always a sense of what is the index of microcirculatory resistance. Is that also how you would see that?
Of course, that's an important point that you make. I mean, we do know that patients who do have microvascular dysfunction also following PCI, for instance, for significant epicardial disease, they still do have angina. They still do have symptoms. And so if we are going to integrate these measures in our daily practice, we're going to be able to target those microvascular dysfunction patients and improve their symptoms, maybe.
Yeah, absolutely. Yeah, so then you have a more complete picture of epicardial and microcirculatory disease. And I think and with the little extra effort, because the only thing is what you need to do is the mean aortic pressure, you have a more complete picture of the coronary and microcirculatory physiology, basically.
Yeah. You may have QFR as a one-stop shop for the whole coronary physiology, and that's extremely fascinating, I think.
Yeah, and of course, up till today, we do the QFR for the main vessels. But as we also further improve on automation, it is, and you have the proper acquisitions, then it's also very simple to do the QFR and IMR also for each of the individual major vessels. So that is also a matter of further automation, and as you have probably seen, the version 2.2 is already a lot more automated, and we are making it simpler and more automated as we go. So it should really be a very simple tool to use in your daily practice.
Yeah, I agree with that. It has been a lot of enormous leaps in the development of the software. It's getting always more intuitive, more automatic, and the manual part of it is getting smaller, which is which is an extremely good thing for daily practice, for fast using, fast calculation in the cath lab. It's really promising.
Very good, excellent. And then, yeah, at a certain point in time, with all your work and the publications, I hope indeed that it can be included in your daily practice. I mean, yeah, what obstacles would there still be? I mean, we try to do our best, and then it is up to the department, of course, and financial department and maybe reimbursement issues that or the total coverage that you get for a particular patient, that it can be included, say on a daily basis.
Yeah, that's definitely a point. And I mean, you also addressed the point of radiation exposure. I think radiation exposure we need for QFR to have an acquisition of at least 12.5 frames per second, which is not a lot, but it's already a bit more than what many centers are doing. So it was the other piece of research you quoted.
Yeah.
We've done a retrospective study in which we included almost 500 lesions, which have been invasively assessed by means of FFR, and in which angiography was performed at 10 frames per second. And in this population, so a very large group of lesions, we saw a very high diagnostic accuracy of QFR. So we saw an area under the curve of 0.92. So very high quality, similar to what previous trials or previous retrospective studies found with 12.5 frames per second. That means we may be able to reduce radiation exposure to 10 frames per second and still be able to get those information from QFR in a very reliable way. And that may not be as important for patient, because the patient is just going to get 1 or 2 or 3 coronary angiography, hopefully just one in their life, because that would mean that we've done the job properly. But still, the operator, especially if you're going to use radial access, which is associated with more radiation, large volume operators, high use of radial access, and so on, maybe also structural procedures, which are also associated with a lot of radiations as well as coronary, and you're just able to reduce those exposures by means also of a reduction of frames per second. And that's a nice finding, that you're still able to get a proper QFR measured. So
yeah, and also with that, I mean, I think great work that you did and do, of course. And again, this paper is under review, but it has multiple advantages at a certain point in time. Since we are dependent also on the calculation of the flow velocity, we need a certain number of frames to calculate that flow velocity. But if we also improvements in the algorithms, and also lowering the radiation or lowering the frame speed, with that also you can say lower your radiation dose and still get very acceptable say results. So this is also excellent work, and also driving it towards the daily use. And also, if you acquire for a particular patient a number of standard views that you can always derive from those standard views, the QFR for either one or the other vessels, then at least you have minimized also your acquisitions. You can do your QFR and then do the PCI, and with that say minimize the number of views that you need to acquire for a proper assessment of all the data.
Yeah, that's a good point as well. I mean, all these studies have been done in a retrospective fashion. It means this 500 lesion did not have standardized projections for QFR. Those were just our daily projection that we are going to use in every patient. So it means we do not need to take an extra shot in order to do the QFR, but QFR also works with normal shots, provided of course they do have the 25 degrees at least separation in order to perform the three-dimensional reconstruction.
Yeah. And of course, with all these developments, also say image quality is of eminent importance. If you are able to provide say good or sufficient image quality, then all the analysis will also be simpler and more automated, and require less interaction. And that is something that we can very little or not really influence. So we can do the post-processing and making good images. That is your expertise. And so it's also to your advantage. If you make good image qualities, then all the rest also will be simpler and also of better image quality and more reliability, basically.
Yeah, life is easier with good Android images. Yeah,
Yeah,
you're right.
Absolutely. Yeah. No, very exciting, and I certainly hope that your publication will be reviewed and you get proper. Well, you will get proper reviews, but that they are also positive, and that you have only minimal, say, additions or edits to make to the paper, and that it will be accepted very soon. And so I certainly thank you so much for all your excellent work, and we look forward to follow everything what you are doing. And yeah, maybe we'll see each other at next year's EuroPCR or TCT or any other meeting that is taking place in the near future again.
Definitely.
So with that, again, thank you. This was.